Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
This activity includes discussion of therapeutic products that have not been approved by the U.S. Food and Drug Administration, off-label uses of approved products, or data that were presented in abstract form. These data should be considered preliminary until published in a peer-reviewed journal. Readers should verify all information and data before treating patients or employing any therapies described in this or any educational activity. A qualified healthcare professional should be consulted before using any therapeutic product discussed herein. Off-label therapies have not been approved for the use specified in this activity. This information should not be considered as a recommendation for the use of a drug outside of the recommendations in the currently approved prescribing information. This activity includes discussion of off-license or unapproved therapies. Please consult your local SMPC or its equivalent for further information.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Jazz Pharmaceuticals, Inc.
Hi, I'm Dr. Alana Alamova. I'm an associate professor with the University of Toronto and head of GI Medical Oncology at the Princess Margaret Cancer Centre in Toronto, Canada. Welcome to this activity titled Ready for Launch in Gastroesophageal Adenocarcinoma, Anti-HER2 Innovation in First-Line Management. I'm here with two of my colleagues and friends, Dr. Filippo Pietrantonio, who's the head of Gastrointestinal Oncology Unit at Fondazione IRCCS, the National Cancer Institute of Milan in Italy, and Dr. Zev Weinberg, professor of medicine and co-director of GI Oncology program at the UCLA School of Medicine in Santa Monica, California, in the United States. So I'd like to ask Zev if you would mind summarizing the evolution of current first-line approach to HER2-positive locally advanced or metastatic gastroesophageal adenocarcinoma, which is obviously similar in North America, Europe, and Asia.
Yes, sure. Thanks, Savannah. Nice to see everybody. I'm happy to go over some of the history here with respect to HER2-positive gastric cancer and how we got to where we are. We've known for about 15 years that HER2 is a relevant target in gastric and gastroesophageal adenocarcinomas, based on some early retrospective literature that suggested about 15 to 20% of people are HER2 positive with patients with advanced disease. The guidelines have centered on PD-L1 negative patients receiving chemotherapy plus trastuzumab, which is usually the doublet chemotherapy of FOLFOX or CAPOX or 5-FU and cisplatin. And if PD-L1 positive, defined as a CPS greater than 1, patients are recommended to receive chemotherapy plus trastuzumab plus pembrolizumab. So the TOGA trial, which was again published about 16 years ago, was the first randomized clinical trial for HER2-positive gastric cancer. They ultimately enrolled about 450 patients, randomly assigned to either trastuzumab plus chemotherapy or chemotherapy alone. And that study showed an overall survival advantage to the group of patients who got chemotherapy plus trastuzumab, which was particularly enhanced in the group of patients who were immunohistochemical positive 3+ or immunohistochemistry positive 2+ FISH positives. Now, after that, there was a long period of time in which a number of clinical trials were done for HER2-positive gastric cancer, which were not successful. We won't spend too much time going over those, but it was about a decade of negative trials in both first and second line. Ultimately, as the immunotherapy wave reached us in gastroesophageal cancer, it became clear that there may be a role for a checkpoint inhibitor like pembrolizumab with chemotherapy plus trastuzumab. And originally at Memorial Sloan Kettering, there was an investigator-initiated trial that showed a very encouraging response rate with that combination. And that led to the KEYNOTE-811 study, a randomized phase 3 trial comparing chemotherapy plus trastuzumab, which at that point, of course, is the standard of care, to chemotherapy plus pembrolizumab plus trastuzumab. The study went through various iterations, including a early approval based on a very high response rate in the combination of chemotherapy, trastuzumab, pembrolizumab. Once the final analysis was revealed, it became clear that the profound benefit of this combination was in the group of patients who were CPS greater than 1, where the overall survival and progression-free survival was most enhanced. It was less clear than in the group of patients who had a CPS less than 1, which made up about 15% of the patients in that study, that there was any benefit at all with the addition of pembrolizumab to chemotherapy plus trastuzumab. And once the dust settled on this trial, ultimately the FDA in the United States agreed that the recommendation to use chemotherapy plus trastuzumab plus pembrolizumab should be restricted to those patients who were HER2 positive and CPS greater than 1. As expected, there was no safety signal in that group of patients, and KEYNOTE-11 ultimately became what we would consider the de facto standard of care. And that is sort of how we got to where we are today prior to ASCO GI of 2026.
Thank you, Zeth, for bringing us up to date. I agree this is where we are. And I guess I'll ask you both, what do you think are the gaps in care currently, and why are more options still needed for this patient population?
Yeah, so I can answer. Definitely, immunotherapy was a great achievement in HER2 positive disease. So this is our benchmark for the future. But of course, HER2 directed therapy is evolving very quickly. And for more than 10 years, there was not so much innovation in the field of HER2 positive disease because many trials failed. This is because of the heterogeneity of HER2 status in gastric cancer, the expression levels, the co-alterations from a genomic point of view, so resistance alterations driving primary resistance, secondary resistance. And it's important to note that after trastuzumab-based therapy, there may be loss of HER2 status, and this may be the explanation of several negative second-line trials. So basically, we needed something more effective. Of course, ADCs had a major role in this setting, in particular trastuzumab deruxtecan, but also more recently bispecific monoclonal antibodies such as zanidatamab, or in a trial from China, ambenetamab. And this is just the beginning because there are several experimental agents on the horizon. So, and we are reaching a level of more effective HER2 targeting, and we really boost inhibition of this target, which is really important. And in many patients, it's a major driver of the disease.
I agree with you, Filippo. And I think what we can start off by doing is reviewing the Horizon GA01 study, which we presented at GI ASCO this year. Horizon GA01 is a phase 3 study including 914 patients. We looked at unresectable, locally advanced, recurrent, or metastatic gastroesophageal adenocarcinoma. And I think what's really important is that all patients were confirmed to be HER2 positive centrally. And I agree with you that probably the reason that many other studies failed is that they did not do this. The study was complex in that it included 3 arms. Arm A, which was the standard of care arm when the study was designed, was trastuzumab plus chemotherapy. Arm B, zanidatamab plus chemotherapy. And then Arm C, which was zanidatamab plus tislelizumab plus chemotherapy. And I think what's really important to know about the study is that standard antidiarrheal prophylaxis of loperamide, 4 milligrams twice daily for the first 7 days in cycle 1, was mandatory for both of the zanidatamab-containing arms, and this was based on the results from the phase 2 studies. At the first interim analysis, the progression-free survival was improved by more than 4 months, and overall survival, particularly looking at Arm C with zanidatamab, tislelizumab plus chemotherapy versus standard of care, was also improved at 26.4 months, with a hazard ratio of 0.72, which is very clinically meaningful. When we look at the zanidatamab plus chemotherapy arm, this had not yet reached statistical significance at the first interim analysis, but here too there was a trend towards improved overall survival of 24.4 months versus 19.2 months, and a hazard ratio of 0.8. What really surprised us when we look at the key efficacy findings of Horizon GEA is that patients benefited regardless of PD-L1 TAP score. Of course, approximately 30% of patients in the study had a TAP score less than 1, while about 70% had a TAP score greater than or equal to 1. Also, when we look at the median duration of response, this was longer in the zanidatamab-containing arms and approached 21 months in zanidatamab plus tislelizumab plus chemotherapy arm. Diarrhea was the most common treatment-related adverse event. This was more common in zanidatamab-containing arms, despite the antidiarrheal prophylaxis. However, what I really want to point out was that the need to discontinue zanidatamab in in either of these two arms was extremely low. It was less than 3%. Filippo, can I ask you to tell us a little bit more about the first line data with TDXD, which I agree is a very promising agent in this space?
Yes, sure. So first of all, TDXD, trastuzumab deruxtecan, is nowadays approved in pretreated patients with HER2-positive disease. And this is based on the results of the Destiny Gastric 1 and 2 studies. And nowadays, all the major guidelines recommend to really test HER2, also to drive second-line treatment decision-making. So not just for the first line, but also for the second line. Gastric 1 was a randomized phase 2 conducted in Asian countries, while the Destiny Gastric 2 was really aimed at generalizing these results in North American and European patient population. And the results were quite similar. So the overall response rate is very high with this single agent. The monotherapy exceeded 12 months overall survival in both trials. So this is the reason why this agent is approved in several countries globally. But of course, there was the need of other trials. And the Destiny Gastric 4 study, for example, is very important because it's the first phase 3 study with this agent in gastric cancer. And it was specifically conducted in the second-line setting to establish the positioning of trastuzumab deruxtecan in the current treatment algorithm. In this trial, patients underwent a new biopsy after failure of trastuzumab-based therapy, and central confirmation was required. Patients were randomized to either the standard of care in the second-line setting, which was at that time ramucirumab and paclitaxel versus TDXD as experimental arm. And actually, the primary endpoint of overall survival was met with more than 3 months absolute gain in overall survival, reaching also a median value of 14.7 months overall survival. So why not putting this agent in the first line setting? This is the reason why the Destiny Gastric 3 study was designed to really investigate the safety and the preliminary efficacy of several TDXD-based combinations with immunotherapy, with chemotherapy. So in the first line setting, the Destiny Gastric 3 study established the combination of TDXD plus capecitabine or 5-FU with or without immunotherapy as a potential strategy to be validated in the phase 3 setting. In the Destiny Gastric 3 study, we saw a very interesting thing that we need to use reduced doses of TDXD, 5.4 milligrams per kg, compared to the approved dose in the second line setting, which is 6.4 milligrams per kg, plus reduced dose of fluoropyrimidines, either 5-FU, 600 milligrams per square meter for 5 days, or capecitabine, 750 milligrams twice daily. Basically, we were able to reduce the prevalence of grade 3 or more treatment-related adverse events and serious adverse events, and reduce the risk of severe interstitial lung disease and even treatment-related deaths. So with these reduced optimized doses, the treatment is quite feasible. Updated efficacy results of the new cohort with 5.4 milligrams per kg of TDXD showed superimposable results compared to the previous cohorts with higher doses. In the updated results of the cohort of 5.4 milligrams, basically the overall response rate was 75%, which is basically superimposable to the response rate of zanidatamab in combo with chemotherapy or the KEYNOTE-811 regimen. So I think that this is really the rationale for the ongoing phase 3 studies. DXD-based combinations are explored in the phase 3 setting in the Destiny Gastric 5 study. So we have a great number of Destiny studies in gastric cancer, and now this study is really exploring TDXD combinations according to the PD-L1 expression versus standard of care. So chemotherapy plus trastuzumab or chemotherapy plus trastuzumab and pembrolizumab.
Thank you, Filippo, for that excellent review. Zev, can I ask you, what about the data with HLX22, which, as you know, is a HER2 targeting monoclonal antibody, which actually targets a different epitope than trastuzumab? I think this is interesting because HLX22 is actually being combined with the trastuzumab biosimilars. Can you walk us through the data?
So this whole new wave of anti-HER2 therapies has led to different directions. Obviously, we see that with the success of zanidatamab, a bispecific. We see that with successful data that Filippo commented on with TDXD and ADC. So people are trying to find better ways to effectively shut down signal transduction through HER2 pathway, or to enhance ADCC and all these other ideas that people think these drugs might work. So HLX22 is a Chinese molecule It is a monoclonal antibody that binds a different epitope than trastuzumab within subdomain 4. They've presented some small data sets, which were updated at ASCO. There's a small randomized, I guess we'll call it a randomized phase 2 trial, since there are only 30 patients in each arm. They looked at chemotherapy trastuzumab biosimilar with HLX22 versus chemotherapy to the trastuzumab biosimilar and a placebo. And the purpose of the study was to get some signals in progression-free response and overall response rate. And they did that. I think their median PFS hadn't been reached as of the data cut at ASCO, whereas the placebo plus trastuzumab plus Capox, again without immunotherapy here, had a median PFS of 8.3, which is about what was expected. It does raise some questions, obviously. Is this strategy of using two different antibodies to block two different epitopes within HER2 any different than using a bispecific? Is there any suggestion that this is somehow better or worse? I don't think we know any of that yet. There is a phase 3 trial that's been planned that is ongoing with this molecule. I will point out, though, the question here of whether immunotherapy should be added to this is not being explored, to my knowledge, in that phase 3 trial. So we could be in a position where we're still guessing as to what is the optimal HER2 strategy once the data sets are released from these trials. Beyond that, of course, there's a number of other phase 3 trials exploring HER2 in gastric cancer. In addition to Destiny Gastric 05, which Filippo mentioned, there's other trials, including the Artemide Gastric phase 3 trial, which is looking at the combination of rilvegostomig, and that's a bispecific of PD-L1 and TIGIT. That's in two of the experimental arms in that study, with either TDXD plus chemo or chemo plus trastuzumab. A few things have happened since the launch of that study. Number one, there's been more negative data with the TIGIT pathway over the last year. So we are walking into that trial now with a little more skepticism about the role of blocking TIGIT in this disease. Number two, of course, all the other data that's emerged about adequate control arms. We'll have to wait and see how that works out. There's also other additional smaller trials looking at other different ways to block HER2. So there will be a number of years up ahead where we'll be involved in testing some of these drugs, which is exciting.
I agree with you, Zev. I'm even more excited in seeing them move into different settings outside of metastatic disease. If we now, sort of move into a case discussion, perhaps we can talk through that together. So we have a 60-year-old woman. She's a non-smoker. She was previously fit, very active. She uses alcohol infrequently, and she does not have a family history of other GI cancers. She presented to us with fatigue, unintended 15-pound weight loss, which is sort of the usual story, and then most recently emesis for the past month, along with dysphagia. She has a past medical history of hypertension, which is controlled with medications, and she had a cervical disc fusion at the age of 45 for other reasons. So the only medication she takes is an antihypertensive. Of course, she's referred to a gastroenterologist. She has an EGD, which shows this invasive mass in the gastric cardia extending into the G junction, which is why she's having this issue with dysphagia. The biopsy has returned as moderately differentiated adenocarcinoma, and she's had a CT scan showing thickening of the upper gastric wall, bulky lymph nodes along the region of the cardia, and lower mediastinum, and then 4 lesions in the liver. So obviously this represents stage 4 G-junction adenocarcinoma. Can I start by asking you, Filippo, what biomarkers do you need to know now? And how are you approaching that in Italy?
We need to start the first-line therapy, so we need biomarkers, of course. So usually we test a 4 to 5 panel of biomarkers, which allows us to perform basically immunohistochemistry testing of HER2, as we said, but also PD-L1 and for mismatch repair deficiency and for Claudin 18. This is important because, of course, the treatment algorithm in the first-line setting is depending on these biomarkers, and sometimes we also test for EBV status to drive immunotherapy decisions. Of course, we know very well the algorithm for HER2 testing, and basically in immunohistochemistry 3+ disease, the patient is eligible for HER2 targeted therapy up front, and in 2+ disease, we need to perform in situ hybridization testing, and if there is amplification, of course, the patient is considered as having a HER2 positive disease. Regarding PD-L1 testing, of course, there are different scoring systems. In gastric cancer, we need to evaluate the stromal component and the tumor microenvironment, and so the tumor cells are not enough to really distinguish between immune sensitive versus immune excluded disease. Basically, we have two different scoring systems. The CPS, which is well known and started a long time ago. Of course, this is a ratio. It's not a percentage, and we have to evaluate PD-L1 expression, not just in the tumor cells, but also in the immune cells, but specifically only in the lymphocytes and macrophages. In the more recently approved TAP, tumor area positivity score, we are evaluating a percentage, and not just lymphocytes and macrophages, but all the immune cells in the tumor microenvironment. It's quicker for our friends in the pathology department, and it can be evaluated easily. Of course, we can use either TAP and CPS because there is a good concordance between these two systems. Of course, it's better to have both and really not linking a specific scoring testing to a specific drug, because instead we want flexibility. And so basically this is what we do in the clinical practice.
Thank you, Filippo. Zeph, can I ask you a question? Is there anything different in the United States about the testing that you do?
No, I think it's a pretty similar paradigm, right? I think we all know that this is a disease where it's protein-based IHC testing, which drives the way. And the four main ones that Filippo mentioned are exactly what we would recommend. Also, some people do tend to also send tumors for NGS testing to get some genomic data, but I don't think for the most part that drives decision-making. It's really a protein-based paradigm right now for this disease.
I agree with you, and I think it's similar in Canada. What we do is our pathologists, if they see a diagnosis of gastric or gastroesophageal cancer, obviously they don't know if it's metastatic or not, but for us, the reflex testing for all four biomarkers exists. So by the time the patient sees us, whether they're localized or metastatic, we would have them all, which I think has improved how quickly we can start these people on treatment. So in this case, the patient's biomarker test results have come back. She has an IHC3 plus HER2 tumor, mismatch repair proficient. PD-L1 CPS is less than 1, and Claudin 18.2 is 35%. What about adding immunotherapy, not adding immunotherapy in this setting?
So this is the big question, and obviously the subject of a lot of interest. So if you were just base it off the Keynote 11 data, you'd say, well, the patient's CPS less than 1, so there's no value to adding pembrolizumab. Obviously now with this zanidatamab data, this whole paradigm perhaps called into question about whether there is value even in CPS less than 1 or TAP less than 1, whatever, PD-L1 less than 1, let's call it, to having a checkpoint inhibitor. So we didn't have time to get into all that, of course, Elena, but you know that better than anybody.
I agree with you, Zev. And Filippo, let me ask you this question. If you had zanidatamab available in the first line, what factors would you consider?
If PD-L1 is negative, in this particular case, having zanidatamab available would be a plus point, because we know that with chemotherapy plus trastuzumab, the progression-free survival and overall survival is still unsatisfactory. So we have a subgroup of patients with long-term benefit, but we really don't know how to identify them before starting the treatments. Having a treatment option with efficacy regardless of PD-L1 status and expression level is definitely a plus point, because otherwise our option would be chemo plus trastuzumab. However, if you mean for a more general question, not related to this specific clinical case, but having seen your study data with the Horizon GA01 study, this is absolutely something that we should consider in light of the progression-free survival and also the overall survival. The overall survival is really solid already, even though this is an interim analysis for the combination arm, Tisli plus zanidatamab and chemo. And still we need more time, more follow-up, more events for the second comparison OS with the replacement of trastuzumab with zanidatamab. So basically, yeah, for the combination, I would be keen to select my patients, more fit patients, to receive the intensive combination to gain really these 7 months absolute overall survival compared to trastuzumab and chemo.
And let me ask you both this question. Obviously, when we make decisions with our patients, there are complex discussions that are being had. So, can you comment on who the key members of your treatment team are and how you go about involving patients and the rest of the team in developing this treatment plan? And who educates your patients about their options, side effects, what they should do if these side effects occur? How do you involve their family, for example? And then also, if you could comment about what do your patients expect from these treatments? Are their expectations reasonable? And how do you manage these treatment expectations?
So obviously, this is the oncologists and the team, which includes often nurses, practitioners, other multidisciplinary team members, nutrition support, nurse navigators, social workers, whatever is needed to help the patient and the family process the diagnosis and help walk them through the options is critical. And it obviously isn't one individual person. The chemotherapy discussions with patients about options are pretty much what oncologists spend most of their time doing. So I think there's really no substitute for getting into the weeds there with the patient and talking through the options, talking through the toxicity profiles and finding the right balance. That's hopefully what we train our younger doctors to do as well. But really, it's critical that we all play a part in helping this. Beyond the options of treatment, there's options of supportive care and many different things that I think we try to get into with the patients.
Yeah. So regarding patients' expectations and the family expectations, every patient is different. I don't have a single way to behave and to communicate. But what I usually do is to consider that we are treating people, not patients. I try every time to understand who really is in front of me, try to understand what is the goal and what I can reasonably achieve with the treatment. Patients are so different. Also, our options are different. So I think that having all these options may be a good way to really allow some flexibility between treatment choices and also to really consolidate the patient and doctor relationship. And this is really important. And all the family is involved. So I think that this is the reason why our work is so difficult, but also really satisfying. I mean, our work is so precious. It's something that I'm really proud of. So it's so different every time. And so I don't have an answer at the end of the day.
Isn't that the art of medical oncology, Filippo? I feel sometimes. It's the trying to put it into context of your patient as a person. I agree with you. It's trying to get to know them and then advise them the best you can. And isn't it a stepwise process that we approach from clinic visit to clinic visit over time, trying to involve multiple other disciplines to support them, understanding that stage 4 disease and everything that we deal with in terms of symptoms is extremely complex. If we can move on into talking about adverse event management, what adverse events are clinicians and patients most concerned about when using HER2 targeted therapies or immune checkpoint inhibitor combinations, in your opinion?
So I think obviously it's different depending on each patient, like we talked about earlier, right? Some patients have a particular aversion to certain toxicities, and that has to be kept in mind. I think we start with the premise that, everybody has some side effects with all treatments. Some of the ones that we encounter with checkpoint inhibitors are a little harder to define and don't happen in everybody, but could happen at random times. We obviously try to be thorough with respect to the typical stuff, whether it's the risk of GI toxicities or endocrinopathies that are very, very common in these patients. So I think we all sort of have gotten used to the predictable side effects, but also sometimes the unpredictable side effects with immunotherapy. And on some level, you can't really prevent these things from happening. These are going to happen or not. You use judgment about who should and shouldn't get the drugs. And that's part of, I think, the discussion that goes into any drug with the patient. With respect to the HER2 stuff, of course, we know that as a class rule, anti-HER2 therapies could have some impact on cardiac function. So we like to get baseline cardiac function before any of these treatments are administered and follow that. In some patients, obviously, there is a decrease in ejection fraction that can be clinically significant. So, as part of the guidelines, of course, with any anti-HER2 therapy, we've known that for many years.
And Filippo, let me ask you this question. Do you currently use prophylaxis with standard of care with any of your regimens?
Yes, definitely should be used with some regimens. There are some specific adverse events with specific regimens we should be aware of, and we should also try to prevent them as much as possible, or at least reduce their severity and be able to monitor when these side effects emerge. For TDXD, we know it's interstitial lung disease. For these particular side effects, there is a very well documented guidance, not just in the clinical trials, but also in the guidelines on how to manage these adverse events based on the severity, the onset timing, and of course, the resolution patterns. And for zanidatamab, more recently, we saw, and you have been discussing before, the role of diarrhea as a potential class-specific toxicity. And this is something that we have seen just in the Horizon GA study with the combination of fluoropyrimidine chemotherapy plus a platinum, so a doublet chemotherapy. We are used to manage diarrhea and other chemotherapy-related side effects. But this particular side effect of diarrhea is increased by the addition of zanidatamab to chemotherapy. For these particular adverse events, the protocol mandated a specific prophylaxis, so I would be keen to do the same in the clinical practice. But also, we need to collect additional data from the study, we need to see real-world data, and we need a guidance on how to manage and prevent diarrhea. It's important to note that this diarrhea actually was evident in the first cycles of the treatment and then improved over time. And this is something that we should consider, because this is not a reason for a permanent discontinuation of the regimen. I really think that education, especially in the community setting, is important, and also providing a guidance on how to best manage and prevent this toxicity. Not because it's very long lasting, but because it may be really important from a quality of life perspective and a patient perspective.
I completely agree with you, Filippo. And as you mentioned, I think that most of the zanidatamab related diarrhea seems to occur in the first cycle and resolves within 3 weeks, meaning that by cycle 2, patients are usually better to proceed with dosing. You know, it is something different. If you remember when we first started using irinotecan, we also had to kind of get acquainted with it. And I could not agree with you more that particularly for people who have not used it before, education is extremely important. So let me then ask you this last question. What do you tell your patients about self-monitoring and self-care, and when they should call your clinic or your nurses?
Well, they should call when something changes from baseline. I think that self-monitoring is important, and also education, not just the oncology team, but also the patient team, the patient and their family. It's really important to educate them on how to recognize a specific side effect. Having scheduled monitoring over time is important for interstitial lung disease with DXD, diarrhea with zanidatamab, cardiotoxicity with anti-HER2 agents, whatever it is. It's really important because, of course, when you recognize earlier any kind of side effect, you can rapidly give some treatment measure or supportive measure and really reduce the severity and duration. So this is going to make the treatment much more feasible. And we know that monitoring may impact overall survival of patients regardless of the treatment they receive.
So if we kind of review what we've covered and potentially the main take-home points, obviously there is the potential for additional anti-HER2 regimens to gain approval in the first-line space, which could lead to a shift of practice for patients with HER2-positive gastroesophageal adenocarcinomas. Obviously, this depends on approval by regulatory bodies such as FDA, EMA, Health Canada. As these treatment paradigms shift and new first-line regimens are used, I think this will bring up questions about how do we sequence subsequent regimens. This has always been a problem for medical oncologists because as the paradigm shifts, a lot of the trials that were done previously don't apply to current patients. As always, involving patients in treatment decision-making is important, especially as more treatment options become available. And then taking a proactive approach to adverse event monitoring and management can help patients remain on therapy longer and, most importantly, maintain their quality of life for longer. So, can I ask both of you if you have any parting thoughts?
No, I think that's a great summary. I mean, obviously, we'll see what the future holds. We have a obligation to develop new drugs and to understand sequencing. So hopefully that'll be the next few years. But great discussion.
Yeah, great discussion. Thank you so much. Thank you, Elena, for being such an amazing oncologist and chair of this session. And thank you, Zev, for this meeting today. It's really wonderful to speak with you.
I just want to thank you both, Filippo and Zev, for your wonderful insights. And I also just want to take a moment and thank the audience for participating in this activity. Please continue on to answer the questions and complete the evaluation at the end of this program.